Good afternoon. My name is Krista Neiman, and I have been a volunteer with the Epilepsy Foundation for almost 2 years. Our next speaker is going to be Dr. John Miller. Dr. Miller serves on EFNW's Professional Advisory Board and is a professor of neurology and neurological surgery at the University of Washington. Dr. Miller also serves as medical director of the Regional Epilepsy Center at Harborview Medical Center, and will be speaking on the topic of SUDEP and mortality in epilepsy. Please welcome Dr. Miller.
Thank you so much for the introduction. I'd like to thank Dr. Novotny and Brent Herman for asking me to speak today, and for the foundation for putting on this program. This is a very serious topic. Some of the things I'm going to say can be a little bit upsetting. So what I tried to do today is have a short, focused talk, focused on the facts. I'd like to emphasize that there are ways to prevent mortality in epilepsy, but it's a serious topic that everybody has to be aware of. Everybody has to discuss with their doctors and have to be aware of what they can do to prevent it. And it's a short talk, so if I get into slip into any medical jargon, just speak up and ask me questions. There's plenty of time for questions and interruptions. I don't mind. So how dangerous is epilepsy? Is there a pointer? Oh, these are mouse. Okay. There's no question that people with epilepsy have a somewhat higher risk of dying than people in the general population. But the risk is really variable. It depends on the underlying cause of the epilepsy, its type, and how severe it is. But many things can be done to prevent or lower the risk. The most important things are that people with epilepsy need to discuss the issue with their doctors so they can understand what the issue is and understand what they can do to lower the risk. And doctors need to not be afraid to talk about this with their patients and try to be sensitive, constructive in the discussions. So what the real message is that it's uncontrolled epilepsy is dangerous, not epilepsy in general, but uncontrolled epilepsy. And overall, the rate of mortality in patients with epilepsy is about 2 to 3 times that of the general population. But it's higher in people with chronic epilepsy, it's somewhat higher in children, and it's higher in people in the less developed areas of the world, presumably because there are regions of the world that don't have the type of emergency medical services that we have in places like Seattle or in the Northwest. The best information on the risk of mortality in epilepsy actually comes from Finland. There's a pediatric neurologist there, Matti Sillanpää, and it turns out that for many years he took care of all the children with epilepsy in this entire region of Finland. They kept meticulous records, and he's followed many of these people for more than 40 years. Also in Finland, there's a registry, and everyone who dies in Finland gets registered with the government, so they have a way to completely track when death occurs for people for any reason. And what he found in this study is that the overall risk of death in people with epilepsy is about 0.7% per year, which isn't that much higher than the general population. But if you take the group of people whose seizures have not been controlled over all these years, the risk is 1.6%, which is actually significant if you think about that's per year, and over many years and decades that can accumulate to a very significant risk if epilepsy is not controlled. Also, he found out that the most common cause of death in people with epilepsy is SUDEP, which has already been mentioned, sudden death in people with epilepsy where there's not another cause. We'll talk extensively about SUDEP in a little bit. And many studies have been done about mortality in epilepsy, and the risk factors have been described as things like cognitive impairment, symptomatic epilepsy, which means there's a lesion in the brain or an abnormality in the brain in the MRI scan that causes the epilepsy, poor medication compliance, or history of status epilepticus. But all these things are just predictors of poor seizure control. It's really poor seizure control that's a main risk factor for mortality in epilepsy. And all these other things are just predictors of poor seizure control. And so what are the causes of mortality in epilepsy? Well, epilepsy, as we all know, is a very complicated condition, has many, many different causes. And some of the causes are things that are progressive. So, for example, someone with a malignant brain tumor can have epilepsy as a symptom of their underlying neurological problem, and that can lead to death. So that's one cause of death. Accidents are an important, potentially preventable cause of death. And the kind of accidents that we worry about the most in people with epilepsy are falls, burns, drowning, and automobile accidents. I'm going to talk about that in detail in a minute. Then suicide is a difficult thing to talk about, but it's important to recognize that overall, if you look at the whole population of people with epilepsy, there's a somewhat higher risk of suicide, and I'm going to talk about why that's true and what can be done to prevent it. And then SUDEP, sudden unexpected death in epilepsy, which is the most important cause. So let's first talk about accidents. If you look at the whole population of people with epilepsy, the risk of them having an accident of any sort is about 50% higher than the general population. But most of these accidents are minor, but the risk of hospitalization from an injury from an accident is higher in people with epilepsy than the general population. Drowning is one of the type of accidents, and drowning usually occurs in the bathtub or the swimming pool. And so there's at least some potential for preventing some of these drownings, and it's important that doctors talk to patients about this and make sure that everybody's aware of this special risk. And there's no question that it's a very dangerous thing for somebody to have a seizure with loss of consciousness while they're driving. That can lead to injury to themselves or even death to themselves or to another person. But it's also important to acknowledge that the rate of accidents in people with epilepsy is far less than the rate of accidents of people who drink and drive. So you have to put the whole thing in perspective. And then work-related accidents often comes up with the relationship to the issue of employment. But you have to put this in perspective too, that the risk of accidents in work depends on the nature of the work, and overall, the rate of accidents in people with epilepsy than the rate of absences is not any different than the general population. So let's talk about injuries from epilepsy-related accidents. Well, this is just a little breakdown from a number of studies just showing some of the more common types of injuries that can occur with seizures. So there are burns, and burns occur most often from household things, so hot water and stoves and that sort of thing. And they more often occur with complex partial seizures where people have a period of behavior with loss of awareness rather than big grand mal seizures. Falls can occur with seizures, of course, and the main danger of falls is head injuries and concussions. And these are more commonly seen in people with convulsions, with drop seizures, and with some myoclonic seizures. And then there are fractures, about 11% of the total. And dental injuries, about 10%. But the most common type of injuries are soft tissue injuries, scrapes and cuts and bruises and things of that sort. And they're most commonly occur in the scalp and the face. So what can we do to prevent accidents? Okay, feel free to jump in here if you have some opinions or comments about this. The first thing is something that is difficult for all of us, which is to obey the driving laws. Because I'm well aware, and you're all aware, that not being able to drive means a major loss of independence. It makes it difficult for people to work and have a normal life. It's a big imposition on people to tell them that they can't drive a car. But there's no question that this is not something that doctors are telling people just because they're afraid of getting sued. There's a real risk. If you have a seizure when you're driving, terrible things happen or can happen. So it's necessary that patients with epilepsy obey the law and that doctors advise them about what the law is. And the law varies from state to state. It's determined by state. In Washington state, the law is that people should not be driving a motor vehicle unless they're free of seizure with loss of consciousness for 6 months. It also applies to other types of loss of consciousness. So somebody has for example, diabetes and loses consciousness because of an insulin reaction, that matters too. So any loss of consciousness, any episode of loss of consciousness requires that somebody not drive for 6 months, unless there's a specific exemption. And 6 months is the most common interval, and the Washington state laws are very similar to most states. In the Northwest, Idaho and Washington and Alaska all are non-reporting states. So physicians are not required to report seizures to the DMV. Oregon and California, doctors are. So if you live in Oregon or California and you tell your physician that you've had a seizure, they have an obligation to report that to the DMV. Another thing is water and drowning, and patients with uncontrolled seizures, especially with convulsions or episodes of loss of consciousness, should take showers or baths. Take showers instead of baths, sorry. And they shouldn't be swimming without careful supervision. One thing that sometimes doesn't get discussed or gets overlooked is hot water. Because if somebody has a seizure taking a shower and the water handle gets bumped and the water is scalding hot, you can have a serious burn. And such things do happen. And one of the things that's an easy way to reduce this risk is to go to your hot water heater and dial down the temperature just a little bit and make sure that the hottest temperature that comes out of your hot water pipe is not hot enough to scald. And that can make a difference with this type of injury. Now, different professions and different activities have very specific restrictions. For example, the FAA regulates flying, and most often patients who have any history of seizures are not allowed to have a pilot's license. Commercial drivers, bus drivers, military, and police all have restrictions, but a lot of times the restrictions vary depending on the state or local government.
I know I have a restriction, and I work in food service.
Yes?
And when I come in, I have to tell them what time I can take in my medicine and how long it will make me drowsy. Because of the fact that we work in such hot ovens, second and third degree burns are possible by me and my coworkers. And I have to report what time I take in my medicine, and then I figure the drowsy effect will be over.
That's unusual.
Yeah.
And that's not a legal thing. That seems like that's a workplace restriction.
At work,
Yes.
and they want to make sure, for my sake, more so, because if, people say, well, they're not supposed to ask you that. Well, from their end, I can see the liability and the suit, a lawsuit saying, well, you didn't regulate her, or you were not paying attention to her. And under the ADA, I know, and this is why I tell it to them, because there are some days that I come in there and I want to go to sleep, and they just put me in the office and tell me to sleep it off and then go to work. But I can understand what they're asking for, because you're in hot ovens, you bring in and out stuff, you can burn your coworkers.
Right. Well, there's the issue of workplace requirements and so forth. And Bob Frazier is on the board of the Epilepsy Foundation, local Epilepsy Foundation chapter, and he's an expert in these topics. And one of the things that you can do is, if you have questions about the conditions under which you work and the restrictions they place, is you might call him or his office, which is actually affiliated with our center at Harborview, and ask for advice.
I know a lot of people say, why should I even say anything about it until I can see why?
Okay. Well, work is an important topic. So let's go on to the issue of sports, because we get asked about sports all the time, and the advice about sports might depend on specifics of what somebody's doing, but in general, most sports are allowed. But there are things that clearly should not be done, and one is skydiving. Although I've had patients skydive and not tell me about it. Rock climbing without a harness, and going up and cleaning your gutters is not a sport, but that's not a good idea either. And scuba diving is a particular thing, because if you're 100 feet underwater, then you have a seizure, that would be extremely dangerous. And there's also some concern that the increased pressure of scuba diving might be a trigger for seizures in some people. That's something that's controversial but possible. And then there's also the issue of protective headgear. I mean, the practical issue with protective headgear is that it's hard for most people to wear in their everyday life, but I certainly recommend it for patients who have frequent drop seizures or have a history of severe injuries from falls. And one of the most difficult things to talk about is suicides with epilepsy. This can be disturbing to even think about, but I think it's important to talk about this and the other issues we're talking about, because if you don't understand these things, you don't know what to do to prevent it. And so I think we have to be open about these things and discuss them. And there's no question that the risk of suicide is increased in the group of people with epilepsy as a whole. And the best data is actually from Europe. They have great medical records and great public health studies in Europe, and this is from Denmark. But the risk of suicide in people with epilepsy is about 3 times higher than the general population. But why is this the case? Well, maybe suicide is something that's hard to know what the cause is, because there are multiple causes. One cause is that suicide is more common in people who also have depression or other psychiatric issues. And there are other psychiatric diagnoses, such as bipolar disorder or borderline personality disorder, that are definitely associated with a higher risk of suicide. And so, at least in part, some of the increased risk might be related to associated psychiatric issues, particularly depression, which we'll get into in a minute. Many of you are aware that there's an FDA advisory that's attached to the package insert for every seizure medication, saying that there's a small increase in the risk of suicidal thoughts and action with any anti-seizure medication. This is actually a controversial subject and a complicated subject, because there are other studies in addition to the study that the FDA advisory is based on, that don't show the same association. In fact, there even are 1 or 2 studies that show individual drugs might lower the risk of suicide. So it's complicated. And the FDA advisory isn't very helpful for us, because it says every drug has the same risk, and people with epilepsy have to take treatment for their condition. So it's really not very helpful, and we really don't fully understand what this association is. So, as I said, the studies are controversial, and there needs to be more work on this topic so we can understand it better. But it's not a reason not to take your medicine. Okay, so like all these topics, the real key is what can we do to reduce the risk? And the real way to reduce the risk, other than, I don't want to get too political about locking up the guns, might be a good idea, but the main way the doctors we try to reduce this risk, and that everybody can try to reduce the risk, is to treat associated psychiatric issues. And the big one is depression, because there are many, many studies that show that people with epilepsy have a higher risk of depression. And the best studies show that the rate of depression in epilepsy is about 29%, which is higher than the general population. Also, most studies show that there's not a direct relationship between how severe the epilepsy is and the degree of depression. But most studies also show that depression is a major determinant of quality of life. So if you give people questionnaires to ask how their life is going and how happy they are about their life and so forth and so on, depression is the most important factor in predicting a negative quality of life. So depression is something that we need to treat, and we need to acknowledge, and we need to deal with. And there's also no question that depression is undertreated in people with epilepsy. So how do we treat depression? Well, a few years ago we had a study which tried to pioneer home treatment methods for depression, where we had so-called life coaches go out to people's houses and try to work with them to deal with depression. And it was actually somewhat successful. It was with Paul Chernowski, this so-called PEARL study, and it was actually had definite positive results, but it's also something that's hard to fund with our healthcare system. So maybe that's something for additional healthcare reform. But the mainstay of treating depression are three things. First is lifestyle changes, and this cannot be overemphasized. That increasing social connections, increasing physical activity has a beneficial effect on mood. That's very important. Counseling is also effective. Not everybody with depression wants to pursue counseling, but it can be effective. And then finally, there are medications. When you go see a doctor and the doctor feels you're depressed, they're prone to prescribe medications. And why do we do this? Because it's easy. Because we can write a prescription hand to you and we've done something. We feel like we've done something. But for many patients, medication does not work or may not work any better than the other things. So you can't neglect counseling, you can't neglect lifestyle changes. They may be more important than medication treating depression. Then there's status epilepticus, which is a special kind of seizure, which is particularly dangerous. Status epilepticus really means either a continuous seizure that goes on and on and on without stopping, or a series of seizures that are so close together that the person doesn't wake up or regain awareness between the seizures. And for many years, the traditional definition of status epilepticus is this process going on for 30 minutes or more. Now, in recent years, most neurologists have changed this to be 5 minutes. And the reason for that is that 30 minutes is too long. We really need to intervene much quicker to get the best outcome. And so most neurologists now say that 5 minutes of continuous seizure activity or repeated seizure activity requires intervention and should be called status epilepticus. Now, as scary and dangerous as this is, there are studies that show that prompt treatment of status epilepticus, even outside the hospital, even by emergency medical services, can be very effective, and the outcome can be excellent. And so people can go through episodes of status epilepticus and properly treated and have a good outcome and have no lasting ill effects from that. It's possible. However, if the treatment's delayed or the seizure, status epilepticus doesn't respond to the treatment, it's quite serious, and the mortality rate for status epilepticus could be as high as 20%. But it depends on the underlying cause. For example, if somebody has a serious brain infection as a cause of status epilepticus, their outcome would be expected to be worse than if somebody had chronic epilepsy and had missed doses of medication, for example. But it's a serious condition. And this is also something that we can do things to prevent mortality and improve outcome. But the mainstay of dealing with status epilepticus and helping people in that state is rescue medication. And rescue medication means something you do at the time of the event to stop it. And this is not only done by EMTs, but it also can be done at home by family and caregivers. And the mainstay are what are called benzodiazepines. Benzodiazepines are a class of medications that include lorazepam, which is Ativan, diazepam, which is also called Valium, and midazolam, which is also called Versed. And these three medications are often used acutely at the time of the seizure, the time of the status epilepticus or acute seizure, to stop the seizures. But you can imagine if somebody's in a seizure, you can't give them a pill. You have to give them this medication by some method that gets in their system quickly, that you're able to give to them. And so there are all kinds of ways that have been developed to give these rescue medications to patients in a seizure. The most commonly used is rectal, which is a commercial product called Diastat, which is a diazepam gel, but there's now a generic version. And so that's set up for administration in the rectum, and this gets absorbed very quickly. Within a minute or so, it can stop a seizure in its tracks. And for people who have a history of this, they should have it on hand to intervene. But there are other ways to do this. One is nasally, and you can give a nasal spray, and the most common drug used for nasal administration is midazolam. And it's possible for the pharmacy to give you a kit, which includes the drug, includes a way to give it nasally. And I know that Dr. Novotny at Children's has set up this is a standard thing to give to children with severe seizures. It's also possible to give it buccally. Well, what does buccal? Buccal is your cheek. Bucca is Latin for cheek. And so you can give this medication inside the cheek and it gets absorbed that way as long as the person isn't spitting out the medication. And even some of these other preparations that are used by other routes can be given buccally and can be helpful, which is particularly good if the seizures aren't severe and the patient's out in public, where rectal administration is not possible. And then intravenous and intramuscular. Yes?
I have a question for the parents. We are having issues with our school district as far as giving the medication, even though we now have a new house bill. And I don't want to interrupt your presentation.
Oh, that's fine.
I would sure love insight from families. Because originally our daughter was given, we have this diazepam to give her, and they said they were going to get it to her rectally because it's too invasive, and middle school is very embarrassing. So we got diazepam, and now we've been fighting with the school nurses who are refusing to designate school employees. We have teachers who have volunteered to be trained to give it to her when the nurses are present because our school district can't afford to have nurses full-time middle school and elementary school. And the thing that's so hard for us is my husband and I are employees of the district. And so I don't mean to interrupt you, but I sure would like to hear from somebody else because it's a passion of ours to try to protect all of our kids, not just our child.
I think this is a major emphasis of the Epilepsy Foundation. I think Brent and Rusty can comment on that.
Well, maybe after your talk, John, I can come back to the podium for a minute and let you know what's the status.
It's absolutely an important topic, how to respond to seizures in school. And one of the things I want to emphasize about rescue medications is that when is more important than how. Because there's lots of ways to give this stuff. But the sooner that it's given, the more likely it is to work, and the better the outcome. And so if your family member is having a seizure, don't take your watch and wait for 30 minutes to give this. Earlier administration is more likely to work. An example of this is we actually did a study, several of us who work at Furcrest. Furcrest is a facility that has many patients with severe epilepsy, and neurologists from the Epilepsy Center go up there and provide consultation. And so we organized a study to compare rectal diazepam versus IV diazepam for treatment of severe seizures. What we found is that the patients did somewhat better with the rectal diazepam than the IV. And the reason is it takes a little bit of time to get the IV in, whereas if you put the diazepam in, it can be working while you're still fumbling trying to get the IV in. And so, when is more important than how? The other thing that this sort of implies is early detection of seizures, because one of the issues that comes up with some people who are prone to severe seizures, status epilepticus, is what if they're alone in their room at night? And all sorts of things are done to try to address that. One thing is of course, have somebody sleep in the room with them, which, of course, when people are, if you have a 17-year-old male, that's not so popular. Another thing is baby monitors, which can be somewhat effective. And then more recently, they've come up with these alarms, which are new but intriguing, where you have a wrist monitor that picks up certain types of movement that sets off smartphone alarms. There may be a way to detect these big seizures and rush in and do an intervention. And so I think that's an important thing to think about. And of course, the whole thing with epilepsy is the tension between giving people independence in their own life and not hovering over them, at the same time, safety. So it's a complicated subject. So then, now we're going to go into the SUDEP, which is a huge and complicated topic, but very important. So SUDEP is an acronym, sudden unexpected death in epilepsy. And it really means sudden death in somebody with epilepsy, who has known epilepsy, where there's no obvious other cause. It's unexpected in benign circumstances, so it's not due to trauma, it's not due to drowning or status epilepticus. Most of these cases are unwitnessed, but they can also be witnessed. And in this state, people who die unexpectedly, the state law is that they have a post-mortem examination, but with SUDEP, no cause of death would be expected to be found. Now, if you look at the medical literature about this, that it turns out that is often some evidence that seizure has occurred. Indirect evidence, some kind of injury to the patient that a seizure has occurred, or maybe even being witnessed. And there's a feeling that many, if not the majority of these cases, are seizure related. But there are also witness cases where the patient has not had a seizure, so this may have more than one cause. There may be cases where the event is not a seizure. So what causes SUDEP? Well, this is sort of human physiology, which I'm not going to dwell too much on. But the basic things that can occur during a prolonged seizure is apnea. You can stop breathing either because of loss of respiratory drive from the seizure, from the brain, or also obstruction of the airway. You can have stopping of the heart. You can have pulmonary edema, which is fluid pooling in the lungs. You can have metabolic effects, a low oxygen in the blood, a high carbon dioxide in the blood, and acidosis, a lowering of the pH in the blood because of the high carbon dioxide. And you can have hypotension, meaning the blood pressure can drop. And so you read some of the literature, and then people ask the question, well, what's the main thing that causes this? Is it one of these different things is what really causes SUDEP? It may be actually that the cause is a seizure, and that a prolonged, intense seizure may lead to all these things occurring simultaneously, and that all these things happen at the same time as a consequence of the seizure. And that ties in with the fact that most studies show that the main risk factor for SUDEP is frequent, strong seizures. So of all the studies, the strongest risk factor in all these different studies is that the presence of frequent convulsive seizures is the main risk factor for SUDEP. And there's a lot of other things, but most of these other things are actually predictors of strong convulsive seizures, like drug-resistant epilepsy, a history of non-compliance with treatment. So people who start and stop their medications are more prone to have this problem. A known structural brain lesion, so if there's an abnormality in the MRI scan, SUDEP is more common, but also severe seizures are more common. Younger age of onset, male greater than female, longer history of epilepsy. So this is something where the risk for one individual seizure is very, very small, but when seizures occur over and over again over the years, then you accumulate risk. Another thing is nocturnal seizures, and going back to what we were talking about with status epilepticus, if SUDEP happens at night, oftentimes where somebody's alone in their room, is it possible that we can detect seizures and intervene quickly, give rescue benzodiazepines, or call 911? Is it possible to prevent some of these cases? That's something that needs to be better studied. It's also been shown that in studies where doctors add a second medication to somebody's regimen, that this seems to lower the risk of SUDEP somewhat, even if it doesn't eliminate the seizures. And that suggests that doing things to patients, even if we can't stop somebody's seizures, that if we can reduce them, make them milder or less severe, that may reduce the risk of SUDEP. So that's one of the reasons why people who treat seizures like myself and Dr. Novotny are so persistent, because even if somebody has seizures that's very difficult to control, doesn't respond well to medication, maybe by reducing the intensity of the seizure, we're doing some good and reducing the risk of this. It's also important to put things in perspective and not to panic. one thing to recognize is that SUDEP is rare when seizures are controlled. It's rare when seizures are infrequent. It's rare in people with new onset seizures. And it's rare when a person only has small seizures and doesn't have convulsions. So what can we do to prevent SUDEP? Well, one thing we do to prevent SUDEP is do more research and understand who's at risk and how to prevent it. And there's no question that this is an important area of research, but there's things that we can do now. And the main thing is to control seizures. So there is a study showing that if somebody has neurosurgery to treat their epilepsy and the neurosurgery is successful in eliminating the seizures, the mortality risk in those patients falls to the same as the general population. So you get rid of the seizures, you get rid of the risk of the increased mortality risk. That's very important. And also, as I've already alluded to, if the risk of SUDEP is higher in those with more frequent and severe seizures, even incomplete seizure control should reduce the risk. So we need to work to reduce the seizures as much as we possibly can. I should also note that there's a very small special group of people who have complex partial seizures who have asystole, which means their heart stops for periods of time at the end of or either during or after the seizure, where maybe 20 or 30 seconds the heart stops and then starts up again. This is a frightening thing for us to see. It's fortunately very rare. We probably see this about once a year at our epilepsy center. And the treatment for this is a pacemaker if somebody has this problem. But it's rare. And this is not I don't think this is a major cause of SUDEP. I think the major cause of SUDEP is severe, intense convulsive seizures, not these complex partial seizures that cause cardiac arrhythmias because of autonomic effects of the seizure. But nonetheless, we have to recognize and treat these patients. And then, as I said, it may be that if we could detect nighttime seizures and treat them better, that might reduce the risk. But this needs better study to prove that that's actually the case. So Brent Herman asked me to talk about the SUDEP Institute, which is I think the reason this talk is part of today's program is because the Epilepsy Foundation is emphasizing this problem, both in education and in research. So the SUDEP Institute is a worldwide effort that is led by the Epilepsy Foundation, but in association with CURE and with the American Epilepsy Society and other organizations to prevent SUDEP and support people who have to deal with it. And so the program includes education, targeting doctors, targeting patients with epilepsy, targeting medical examiners, pathologists, and coroners to recognize and to have more awareness of this problem. It's to support research of the causes and methods of preventing SUDEP, including support of a comprehensive national registry. So one of the issues with SUDEP is we don't always know when it happens. And it's not recognized, not diagnosed correctly. And I can tell you that many, many times the neurologists who care for the patients aren't even told that it's occurred, don't even know that it's occurred. And so to understand how big a problem this is, we need a registry, which means that every patient that has this condition should be registered nationwide so we understand how big a problem this is. And then there's a SUDEP support network to provide counseling and resources for individuals and families that are dealing with this problem. So the goals for this year for the SUDEP Institute are to include SUDEP as a part of epilepsy education, like today's program, and also for care guidelines. They intend to hold a workshop for medical examiners to determine best practice and to detect and register SUDEP, to update the education material to include current information on SUDEP, to improve support services for SUDEP, through the Epilepsy Foundation, and to consolidate and promote research opportunities in SUDEP, and to promote the creation of a national SUDEP registry. So here's my concluding slide. One thing I want to mention is that many physicians don't really appreciate the mortality risk of epilepsy. And there's a historical basis for this. This is a quote from William Gowers. William Gowers is one of the British neurologists who was one of the founders of modern neurology. He described almost every neurological disease that exists. And he wrote in 1885, the danger to life of patients with epilepsy is not great. And this is really entirely true. It depends on the patient. It's true that the risk of death with an individual seizure is very, very, very small. When somebody has uncontrolled seizures over year after year after year, there is some risk. And we have to pay attention to this and use that and do what we can to minimize the risk and acknowledge it. The main way to reduce the risk of mortality is to reduce seizures. So anything that can be done to reduce the frequency and intensity of seizures reduces the risk of mortality in epilepsy. Other ways is to take appropriate precautions against accidents and to treat depression. So in summary, the purpose of epilepsy treatment is not only to improve the quality of life, but to save it. Thank you.